Welcome to Now Serving a Site of Therapy, a client's introductory guide into the therapeutic world. Be sure to follow, subscribe, and comment on YouTube, Spotify, and Apple Podcasts. To schedule a therapy appointment, call us at 650-223-5065. For more information on this and other related topics, check out our blog at isotherapy.com, where you can also contact us through our website. I'm your host, Dalton Huckaby, a licensed marriage and family therapist, and I'm grateful you've joined me. Okay, so welcome to this week's episode of Now Serving a Site of Therapy, a client's introductory guide into the therapeutic world. Today, we are joined by Joe Gutierrez, who is a licensed marriage and family therapist. He brings a unique perspective to therapy through his background in international business and clinical training at Harvard, Santa Clara University, and Notre Dame de Namur. Joe also holds a separate license in substance use disorders, making him well qualified to support his clients with these challenges. Joe manages a private practice, and he shares his unique experiences and knowledge base in the role of a group supervisor at 2 agencies and is a frequent public speaker on substance use. Welcome to the podcast, Joe. It's lovely to have you, man, to discuss this important topic. There's so much information to it.
Yes, thank you, Dalton. Thanks so much. And let me just kind of provide an introduction, an overview to what we're going to, for our listeners to know what we're going to cover over the next little bit. And so our main topics will be the following: what addiction is, so kind of putting some definition around that, and then exploring myths versus facts, because there are a lot of urban legends, not all of which are correct.
I love exploring myths in prior episodes, right, on other topics. That's often one of the subtopics, is going over myths versus facts.
And then touching on what cannot be ignored, which is the growing fentanyl crisis, and a really important component of the landscape in today's substance use.
Absolutely.
In the U.S. And then treatment and recovery. So what is substance use disorder? You'll hear me default to that nomenclature. We used to call it addiction. People are addicted. And with such terrible stigmas around addiction, we've shifted our language and nomenclature to be more sensitive to people suffering from, and suffering, I underline that, from substance use disorders. The terminology was changed in the DSM, which is our Bible for therapy, a number of years ago, which is good. The 50 Nation now calls it substance use disorder. And so you can have a substance use disorder. It could be mild. It could be moderate. It could be severe. You could be have a substance use disorder and be in remission. Early in remission, medium remission, or long-term remission. So it's both a medical and a mental health condition, which involves, changes in the brain and the function of behavior. So what basically happens is, if 2 of us go out to have beers one night, and one of us is predisposed, one of us have a family history of substance use disorder. Let's say I do. The chances are 40% likely that I would develop a disorder. It starts small. I need 2 drinks. I need 3 drinks. And all of a sudden, my friend Dalton needs to try to get me out of the bar because I'm on my 5th drink. It's time to go home, and I'm just getting started. So that's where we call you're crossing the line, and you no longer are drinking just to drink. And there's 2 phenomenons which are important here. One is that your body becomes physiologically dependent on alcohol. And no matter how hard you try, you have to have another drink. Your body is dependent upon, you become dependent. And the other piece is, which is very interesting, is that your neurons are rewired to require alcohol and substances. Same thing as with drugs. And so,
Is that where you're talking about kind of like dopamine and serotonin?
yes,
Is that where that comes into play here? Yeah.
exactly. And then it represents terrible cravings, like cravings that you need alcohol or drugs. Continued use, key key um, key indicators when you're working with someone. They have cravings. They're still using, despite negative consequences at home, on the job, friends, and family. And the more they drink, the more their tolerance for that substance increases, and they need more to get more.
Yeah, and I think that that aspect, like you said, like despite the negative consequences, they still continue the use. And that is the baffling part, Joe. Right? They're like, even if they, sometimes at first we might even be in denial that, oh no, it's just impacting myself, right? It's not impacting anyone else, right? But then maybe say they do get to that place of being able to identify, oh yeah, I can see how I'm maybe like kind of it's messing, up my life in these other domains, right? And so, but even still, even when they're able to identify it, sometimes it's still hard to stop. And that's like the baffling part.
Mm-hmm. It is baffling, but they've lost control. And what people need to understand and be sympathetic with, it no longer is a choice. It's a disease. And that's part of the stigma we'll get into later.
Uh-huh.
But common substances that are involved in addiction or dependence are alcohol, opioids, stimulants, cannabis, and sedatives. And please don't discount cannabis as being not a big deal. And please be aware that it's a gateway drug. You start there and move on. But more importantly, heavy use of cannabis by adolescents actually reduces short-term memory and can reduce IQ by 1 to 2 points. I had a client, 15-year-old Boy Scout, Eagle Scout, straight A student from a single family, and they woke up one day, one morning in their car with a rifle in the back seat and 7 felonies.
Holy crap.
It's really common to have people experience a psychotic break on cannabis. And so
especially with the developing brain, you're saying, right? Like,
yes, yeah,
because the brain's not fully developed until they're
yeah.
25.
And when parents say, I'd rather have my kids smoke weed than drink alcohol, say not a good idea. Here's why. So
Yeah, that psychoeducation piece is so huge, right? And as you say, it's kind of like just to try to like normalize it and right, kind of like limit some of that, shame that might be around it too.
yeah, and then we talked a bit about the biopsychosocial factors. It's always good for a therapist. So important to know as therapists that 40 to 60% of the people we see will have either had in their past a substance use disorder or have a current dormant substance use disorder or a active substance use disorder. And so that's and like I said, it's hereditary. So it's always good to do a genogram around, the history as far back as one can remember on both sides, with many factors, but certainly alcohol and drugs.
Hey Joe, what would you say to this aspect? Speaking of the Geneagram, right, and kind of for those kind of listening, it's kind of like this family history, right, kind of diagram that kind of helps us connect some pieces, that way into this kind of family history, if you will.
Yeah.
And so, my question to you, Joe, is what would you say to this idea of like, say, you have two kids, two siblings growing up in the same household, they're both exposed to substance use in the household, even moderate, severe drug use, right, or substance use in the household, and one of the siblings grows up and has, a more of a substance use concern, if you will, whereas someone else might grow up and even from a young age to be like, nope, I don't. I saw the destruction that happens to my family. I don't want anything to do with it, and they don't even touch a thing. What would you speak to, like, kind of those two different types of responses in that situation?
So interesting. I've had identical twins
Wow,
who
even more fascinating. So I'm glad I
identical
asked.
twins who have and it's you bring up an interesting point that's separate from the hereditary nature of the disease. But the dad or mom, whoever is the drinker, and in lots of instances, it's the mother who's the drinker and not the father. A lot of times people assume it's all the male. No, it's
I
not.
mean, it was in my experience, but yeah, not always,
Not,
right?
not,
Yeah.
not at all. And men take a bad rap. Um, but in this case, it just is hard to say. Some of the socializing, some of the modeling, why do people turn out a little differently? Um, and I have the one twin who is struggling and struggles still and in and out of, being homeless, etc. And the other twin who will go have a beer with his buddies, but he can leave after the first drink.
Yeah.
But if you ever want to kind of like do an experiment, if you're at a wedding, step back as the people leave the dining room and watch. There'll be one or two people who are going from champagne glass to champagne glass, emptying, and those are people that have a substance use disorder and need more. It's a disease of more. I need more.
Yes. Yes. Disease of more. Absolutely.
So, anyway, going into myths now, um, addiction is a lack of willpower. Not at all. You know, their brains have been changed and their body has been psychologically, physiologically programmed to do anything to feel better. Anything. And that can go down to stealing, going to Safeway and stealing alcohol or stealing money from friends and family. And you almost become someone else.
You know what kind of makes me think about that, Joe, is like you said, when you say kind of like with substance use, it can be a disease of more, right? And so then, it kind of, it will, we require more in order to sustain those kind of same levels of like dopamine and serotonin, right? What do
Mhm.
you think about this aspect of like adrenaline? Like when you say like somebody goes to steal, right? And I know it's kind of still kind of maybe like an quote unquote addiction of sorts, right? Could be, but there's this aspect of, hey, they're really addicted to the adrenaline. So
Right.
right. You can kind of like in any kind of like addictive quality, it seems like there's this neuroadaptive consideration as far as like why it's that contributes to the behavior.
Yeah, dog. That's a very good point. It's all about um, uh, the high and chasing the high, and the bar moves up, and you're still chasing the high. Um, then people have heard that people must hit rock bottom before they recover. Um, um, that's not true. I mean, oftentimes people hit rock bottom and stay there forever. If you
The
want
way
to,
I've heard it before is like some people get off the elevator floor a little bit earlier than some people do. That I've heard it put that
right?
way.
Yeah, exactly. That's exactly right. But early intervention greatly improves recovery outcomes. In terms of outcomes, we'll get to that later. Unfortunately, outcomes are relatively low. 15%, best 20%. And a lot of that has to do with people being ready and willing.
Yeah.
Can make an unwilling person get better?
And they
And
have to want it, right? Like that willingness and to be ready to change and do something different. And yeah.
and then the next myth is treatment does not work. Well, there's lots of evidence that shows that there are significantly improved recovery rates when someone is in a and it's important to specify this, a recovery program that fits them. This isn't an one size fits all business.
Right.
Different, and everybody's looking for something different in terms of their recovery. And it's important to meet them where they are and be aware of what their needs are.
Yeah, you know what I even think about that too? It's kind of like we have all these therapeutic modalities, right? We have CBT, IFS, motivate, like, and we try different interventions with clients because we want to see which one they best respond to. So similar thing here,
Yeah,
right? Trying these
exactly.
different treatment models to see which one works best for the client.
Yeah, and I love this fourth myth. It's only certain people or types of people become addicted. And it can affect all ages, all sexes, all income levels, all professions, and it's insidious. I have a client. I had a client. She was A+ student, 17-year-old high school young woman, blonde, overachiever,
Life ahead of her.
equestrian rider, and high school cheerleader. Great family, great friends, but she had a riding accident, and she got hooked on oxycodones. And then as a result, she got into heroin, and then got into slamming heroin. That's slang for injecting heroin. And when she came to see me, she was in such a bad space. She was so alone and so desperate. She wanted to stop, but she couldn't tell her parents. And she couldn't tell the school. And if she told her friends, they'd all abandon her and leave her, and she'd be fired from being a cheerleader. She was very alone.
Wow.
So
Yeah, that feeling like right you're in that place because especially if it's kept a secret, right? There can be that shame around it. And then yeah, what's the risk if I tell people, but what's the risk if I don't too?
yeah.
It's a sticky
And so,
situation.
luckily, we found each other, and I was able to be someone that could help her and guide her, right? So the statistics for substance use disorders in the United States are staggering. Over 40% of Americans experience a substance use disorder each year. Of that, by far, alcohol remains the most common at about 20 million. Many people struggle with opioid use disorder as well. A lot of older doctors are the I would say the geriatric audience is coming to a crisis because their PCPs are retiring, and their PCPs would prescribe oxys like candy. And all of a sudden, the new younger PCPs are coming in and saying, no, this isn't a good idea. And so you've got all these older people going through horrific withdrawals and with not a lot of support in the withdrawal.
And yeah, you're talking about, I can't help but think like some, like risk factors, like as therapists, we're trained to like I listen for risk factors. And would you say that there is an age range of whether, for females and males that are more likely to have a substance use disorder?
No,
Is that a thing?
I think it goes throughout the age range, all of them. It's
So
not.
again, to your point earlier, right? It can affect people of all ages, right? To that
Yeah,
point.
yeah.
Yeah.
It doesn't discriminate. All ages, all sexes, um, all. Well, I will say there are certain populations. So the group at the highest level of substance use disorder are transgender people. Very
Uh-huh. Uh-huh.
because they're so disenfranchised from any group, even the mainstream LGBTQ group. Kind of,
Yeah.
it's really awful. But there are certain groups that are more prone. Maybe low income African American and Latino populations, and I'm not quoting numbers, but I'm just speculating that I think that's in my experience. That's where you'll find a lot of challenges.
Yeah, with the socioeconomic status in some cases can have a influence there too.
Yep. Now, the good news is that in the last 3 to 4 years, insurance companies and others have stepped up and become more supportive of making affordable treatment available.
Great. A
And
much need a need indeed, yeah.
yeah, and to give you an example, finally, there's five in San Mateo County. There's five Medi-Cal sponsored treatment facilities for residential treatment. But I did work at what I'll call a high-end, and there are many of these, a high-end treatment facility where I met a lot of very famous authors, very famous actors, and then professional football players who got loaded up with oxys during the season and then had to get back on the field the next, and so they would go to residential treatment. And this residential treatment was like $100,000 for 3 months. There's one.
Jeez.
There's one in Malibu, for example, where you go and you get hot rock massages and you get all this, and
Yeah, luxury, right?
it's a fortune. But more and more, we're finding that we're getting the barriers to care are improving. Actually, now we couldn't have this whole conversation if we didn't talk about fentanyl. So fentanyl is traditionally a tranquilizer for elephants,
Right.
but it certainly has a tremendous high. And that's what draws people to want to try fentanyl. But it's got to be in teeny little doses. So imagine, salt. You put a half shaker into a marijuana cigarette, you'd roll it up and you'd smoke that whole thing. But with fentanyl, one kernel would send you over the moon high.
Is that right?
And so it's become a problem because a lot of dealers lace fentanyl with other things. And a lot of people overdose. They didn't ask for fentanyl. They didn't want to overdose. They didn't want to end their life. They didn't ask for any of that. They just got the wrong thing at the wrong time for the wrong person.
Yeah. Yeah,
And
it's
if
sad.
you can imagine how bad the epidemic is in the United States. So where I live, the 49ers stadium, the football stadium is the biggest stadium up here. What do you have, a Dodger stadium down there? Or what do you have?
We have the Dodger Stadium down here. We have SoFi Stadium as well.
Okay. So This stadium up here holds 49,000 people. So imagine that stadium full for the Super Bowl.
Uh-huh.
Then imagine that stadium empty. That's how many people die in the United States a year from fentanyl overdose.
Wow. Wow. Hmm.
Pretty profound.
Yeah, yeah. It would, yeah, it's quite the tragedy. And like you said, the harm is that like you don't know what you're getting, right? That's the thing. And so
Right.
there's a high risk when we engage in the activity. And so even again, right, we might even have that information and it's like someone who's like active in the substance use, right? And they feel like, oh, okay, well, there's a risk involved, and yet again, sometimes they just still engage in that. It's that high risk behavior,
Yeah.
right?
So,
And sometimes, to your point, it doesn't end well, unfortunately.
so you're right. And so, you know, that kind of describes why it's so dangerous, but what can you do to preventative measures? So
Yes, exactly.
I I always carry 5 naltrexone kits in my trunk of my car. Because if I see someone that's, overdosing, I can quickly administer this and they'll come right back. And I make it
Nice.
available to many people. Anybody that would like some is welcome to. There's also drug testing strips, and the more education that we can provide. I was a guest speaker at a high school, invited to talk about drugs and alcohol, and I spent the whole time talking about fentanyl and being aware of fentanyl. So I guess that moves us to, well, of course, the underscore there is early awareness and early intervention is always helpful. And then I guess we should really also think about uh, co-occurring disorders. So more often than not, AOD, substance use addiction, shows up with other um, diagnoses. So one might be depression and alcohol use. One might be anxiety and benzodiazepine use. One might be PTSD and opioid use. Another might be um, marijuana or cannabis-induced psychoses. And
Mhm.
integrated treatment is very important, and to decide what to treat first. Or,
Right,
or
right.
to,
That's the age-old question, isn't it, Joe?
yep, or treat them together. Now, if someone comes to me and they are so deep into their substance use that they have even problems operating on a daily basis, and they're so unstable, I need to get them stabilized. Then we can work on the depression. Then we can work on. Now, usually, alcohol, for example, will create the second diagnosis, which is type depression. Alcohol is a depressant, it's a downer, and so it makes people feel, we think of it as a celebratory event, right? Drink champagne.
Yeah, there can be this like celebratory fantasy to it.
Yeah,
Yeah.
but it's not true. It's like, for someone with an addiction, it's like pouring um, kerosene on a fire. Now, rarely, and it's
Like
also
drinking alcohol, if someone also has depression tendencies, drinking alcohol is like pouring kerosene on a fire.
exactly. I love that. I like that description.
Yeah,
Now,
I do too. Yeah.
I usually alcohol comes first, and then comes depression. I've had a handful of cases. One in particular I can remember is there was terrible depression from early childhood trauma. Terrible depression. And finally, as a result, the person began to drink, and it made them feel better. And they drank more, and they drank more. Then they became addicted. But it was depression led to alcohol, substance use disorder, as opposed to drinking and then getting depressed because you're drinking too much.
Right. So in that case, you might, if the client's stable, then maybe you can work. You can work on the depression piece since that's what came first. Is that what you're saying?
Yeah, exactly. Exactly. And so a lot of times I'll try to even send someone to a detoxification facility. Now, I don't know if I mentioned this before, and it probably will happen again before we finish, but alcohol is the only drug that will kill you if you try to go off it without medical assistance. It will kill you.
Yes. Yes.
Cocaine, methamphetamine, crystal, heroin, none of the others will kill you. Those are horrible withdrawals. Nightmaric, horrible.
Yeah, people can get, what do you call it? Like seizures or like,
yeah, you need to go to a
right?
padded room, have someone to check, make sure you don't swallow your tongue, and but alcohol needs to be supervised and medication and until they get detoxed. And once you're detoxed, then you can think clearly.
Thanks for tuning in this week. Be sure to check out next week's episode as we continue our discussion with Joe on substance use disorder as we explore treatment and recovery, harm reduction, three-legged stool, and positive reinforcements.